From Microbe TV, this is Infectious Disease Puscast, episode 61, recorded on August 14, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. And I don't really have any banter planned for today.
Right.
I'll throw it over to you again.
Sarah, you don't have to plan it. It's just what
just
comes
happens.
to you. Well, I will. People may notice I'm recording from, my other studio. We have several, right? So I've got like the basement cave with, it looks like this beautiful like stone wall, but it's actually like fake wallpaper. And we were recording a delayed TWIP on Monday night because Friday we had a massive storm here. And it was a massive storm here where like boats were flying off the docks, and I get a call from my daughter, "Can you come help us?" And I'm at St. Francis Hospital, like dressed in my bow tie and the whole. So I go down to the dock like that, helping them rescue the boats, and then the transformer where Vincent Racaniello is explodes. So we delayed till Monday, and then Monday we just finished recording This Week in Parasitism, and boom, my computer exploded just like the Transformers.
That's how it works. It's always all at once. Well, I've had a relatively uneventful week, so you've taken all the busyness. But yeah, well, I will start us off podcast as a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right, and I will start with our viral section. And yes, remember to listen to This Week in Virology, both the clinical updates and the deep dives. And I'm going to start with the article, Co-Formulated Bictegravir, Emtricitabine, Tenofovir, Alafenamide for Post-Exposure Prophylaxis After Sexual Assault, a retrospective real-world study published in Open Forum Infectious Disease. This is a tough topic, and a lot of people addressing this are going to be in an urgent care, primary care, even ER environment. So sort of an important topic. But here the authors report the experience of using bictegravir, emtricitabine, tenofovir, alafenamide for NPEP in sexual assault cases. And here we read that between June 2021, October 2023, 39 individuals completed the 28-day follow-up. 41% experienced some side effects. One person discontinued the drug due to a rash. So just to put that in context, right? There were some side effects, but only one that actually stopped it. No individuals seroconverted to HIV during the follow-up period. So I actually just wanted to use this as an opportunity to highlight the post-exposure prophylaxis after sexual assault, but also highlighting the non-occupational exposure prophylaxis guidelines. And also I'm going to leave in a link to the AETC guidance. And there was recently a febrile, right?
Mm-hmm. It was a little bit, yeah.
PrEP and PEP and other things. So we can even, Sara, you can pop in a link for us. Yeah. But there's a couple of things I wanted to highlight here. So from that resource, we read that healthcare providers should evaluate persons rapidly for NPEP when care is sought less than or equal to 72 hours after an exposure that presents a substantial risk for HIV acquisition. You really want to evaluate to make that decision. And why less than equal to 72 hours? That's based upon a study that some of our listeners are probably familiar with. But HIV prophylaxis, administer that first dose of NPEP on site as soon as possible. The clock is ticking. And you want to get that negative rapid HIV test so you know where you're starting. And then we get some recommendations. Really, a lot of us are using Truvada, Tivicay, right? I'm using some brand names there, but the tenofovir, emtricitabine, and dolutegravir. The nice thing here is you're going to be doing this as a once-a-day regimen because some of the older recommendations had a combination here with a BID. But what I want to point out here is a lot of folks are actually using Biktarvy. right? And there's a lot of ease here, right? Because it's just going to be a one pill, not a one of each pill. And then we get some recommendations about pregnancy, but also don't forget about the other sexually transmitted pathogens. So think about GC, give that ceftriaxone. Think about chlamydia, that doxycycline. You may consider, for vaginitis, your metronidazole. Talk about emergency contraception, hepatitis B prophylaxis, and HPV vaccination as well. So there's really a lot in here to be thinking about when you're in such an unfortunate situation.
And the viral paper I pulled today is from JPIDS, adopting the 2023 CDC early testing for perinatal hepatitis C, call to action for pediatric primary care providers. And I thought this is just a good reminder because the CDC and the Peds ID Bible AAP Red Book do specifically recommend testing for the hepatitis C RNA NAT between ages 2 to 6 months to look for identify these children who might develop chronic hep C infection after a perinatal exposure. And historically, the recommendation was, wait and do the hep C antibody testing at 18 months of age or older, after mom's antibody would have been gone. But I think, there's a lot of challenges in that to say, please get a test in a year and a half when the child is quite young and, testing rates were low and there's a pretty major loss to follow-up. And so I feel like for a while I was still saying 18 months for testing. But if you talk to people who were taking care or like following these patients in perinatal clinic, I feel like they would teach us about how we could get this earlier NAT testing. So this is just a really nice review of that. And I figured just making that statement alone to remind people to do that is kind of enough of a summary of the paper, but they talk a little bit about those adjustments and the recommendations and how that can really help enhance testing. And really their take home is the importance of all pediatric providers and OB docs to help implement that testing, because obviously that's not always going to fall into these sort of ID or perinatal infection type clinics. It's really going to be in those primary care offices. And so they talk a little bit about, the evidence, but also the practical logistics, such as even the annoying thing that happens when you type in a hep C RNA testing for a baby. And if that baby's nursery is at an adult hospital, it defaults to the adult hep C testing, which is an antibody and might need another draw. So I think it's just a really great overview. Of course, you can also reread the chapter in the Red Book, but I think this is a nice background, or I should say supplement for that. Great. And then for bacterial, please be sure to listen to This Week in Microbiology. This first one I thought was really interesting. Lower rates of Staphylococcus aureus bloodstream infection in patients on hemodialysis receiving trimethoprim sulfamethoxazole melioidosis prophylaxis, published in OFID. So it's perfect. It talks about staph, it talks about Bactrim, and it talks about melioidosis. So of course I had to pull it. But it's a single center study from Royal Darwin Hospital in Australia, where they found that Staph aureus bacteremia rates were 56% lower during the monsoon wet season when their patients who were on HD received melioidosis prophylaxis, which is Bactrim. And so these patients received supervised post-dialysis trimsulfa given 3 times a week for 6 months of the year during that wet season. And that's part of their established guideline. So of the 1,145 patients receiving hemodialysis, 52 or 17% developed Staph aureus bacteremia. And so this lower incidence was there when you compared wet season versus dry season. But they also did not see a variation in adults who were not on dialysis. They did find that the trimsulfa resistance rates were higher in the hemodialysis Staph aureus isolates than in what would be sort of the local antibiogram. So about a third of patients having resistance to Bactrim versus 8%. And then of course we all know the side effects that come along with Bactrim. So I don't think we're all going to necessarily jump to putting every patient on Bactrim, but I think it's a really cool question could we use prophylaxis like this for patients who are receiving dialysis or other populations that are at risk? This is a very unique setting, but maybe it's a question that someone can ask and take a look at. They just had the nice advantage of having a guideline and a population that was easy to look back on.
Interesting. Yeah, I also like the fact that, hey, they're using TMP sulfa in people on dialysis. So just a point that can actually be done, by the way. All right. So the next articles, they're kind of a pairing. So normally we try to go back and forth, but these kind of are stuck together here. Two really nice reviews, both in PLOS and TDs. And these really are worth spending a little time. I'm going to say particularly in parts of the world, like here in the Northeast, where we see, or I should say, there are a lot of people that get these infections that we don't realize we're seeing, right? Some of these diagnoses, I'm sure, are being missed. But so the first is human monocytotropic ehrlichiosis, a systematic review and analysis of the literature. And now it gets easy. We're just going to call it HME. We read that cases of HME are almost exclusively reported from North America. Human infections due to other non-Chafiensis ehrlichia species are rare. Now, HME primarily presents as an unspecific febrile illness. So 95% of the cases, it's person just has a fever. Now, sometimes they'll have thrombocytopenia, so platelets being down 79% of the cases. They'll have leukopenia, only a little over half, 57.8% of the cases. We will sometimes see abnormal liver function tests, 68.1%, and immunocompromised patients are overrepresented among the reviewed HME cases. So about a quarter of the folks were immunocompromised, suggesting HME is an opportunistic infection. So first kind of caveat I want to say in my interpretation here is we underdiagnose this disease, right? So these are HME or Ehrlichia cases that have actually been diagnosed, but just I suggest this is the tip of the iceberg. How many non-specific febrile illnesses without thrombocytopenia, without leukopenia, just resolve on their own? Maybe some empiric doxy is given, so just keep that in mind. We also, as mentioned in the same edition, we have the article Human Granulocytotropic Anaplasmosis, a systemic review and analysis of the literature, and actually by the same authors, but in a slightly different author order. So here we read that cases of HGA are seen in all continents, reported from all continents except for Antarctica. HGA primarily presents as, you ready for this, an unspecified febrile illness, often accompanied by thrombocytopenia, abnormal liver injury tests, and leukopenia. Oh my gosh, how do you tell the two apart? Now, the authors found complications reported in a total of 40.5% of the reviewed cases, and severe and even life-threatening complications. Acute renal failure, about 10% of the time. Multi-organ failure, 7.5. ARDS, 6.3. The lethality was about 3% in these cases, and treatment with doxycycline showed a rapid response, with the fever subsiding in the majority of patients within 1 day of starting treatment. So this is, it melts, the fever melts away, right? So sort of like a scrub typhus response, or maybe even typhoid. Unlike in ehrlichiosis, reports of opportunistic infections complicated HGA are rare. HGA during pregnancy does not appear to be associated with unfavorable outcomes. In addition, their analysis provides some evidence that HGA may differ in clinical aspects and laboratory characteristics in different regions of the world. So they say that overall the data analyzed indicated a non-negligible bias in reporting publication. So as I agree with them, a certain degree of caution is required when generalizing all of this data.
Yeah, you have to. I'm glad you presented them together. I specifically didn't insert anything because I feel like you have to say Ehrlichia and Anaplasma in the same.
Yeah, they're very, very, a lot of similar, this is where I bring up, Occam was not a doctor, John Hickam was, because we see, like with Babesia, which we're seeing more and more of, about 20% of the time, something else is going on if you look for it. If you don't look for it, it's still going on. You just don't know.
During our micro rounds today, there was a picture shown with a little morula. So this is perfect. And this next one, I don't know about you, but I think maybe one of the most common questions that patients or parents also ask is about like probiotics. I know people have a lot of interest in that. So I pulled this paper from JAMA Pediatrics, Bifidobacterium and Lactobacillus probiotics and gut dysbiosis in preterm infants, the primal randomized clinical trial. It's pretty good. This phase 3 randomized clinical trial is from multiple centers in Germany. They asked the question of whether administering probiotics with these organisms reduce the rate of colonization with multi-drug resistant organisms or highly epidemic bacteria, which they abbreviated MDRO+. And so looking at whether or not there's colonization at day of life 30 compared to placebo. And so the reason that this comes up is these types of organisms in the preterm gut has been linked to NEC or necrotizing enterocolitis. The AAP does not currently suggest or support probiotics for routine use in preterm infants. And I think a lot of that probably has to do with some of the recalls for contamination and the quality of the products. But and then I should have said primal stands for priming immunity at the beginning of life. So in 618 preterm infants, these were 28 to 32 weeks gestation. MDRO colonization occurred in 37-ish% receiving probiotics and 37-ish% receiving placebo. So basically the same. The probiotics did modulate the composition of the microbiome towards patterns typical of healthy full-term infants, but ultimately this did not lead to reduction in colonization of these organisms at 1 month of age or any significant impact on clinical or safety outcomes, so sepsis, GI complications, and so on. They did find a substantial amount of probiotic bacteria in 49% of the infants treated with placebo, which they think is related to environmental uptake in the hospital environment. And Bifidobacterium infantis had a particularly high capacity to colonize the gut in particular. So this meaning like twin siblings that were in the same beds, but also like singleton babies that were in their own crib or bassinet or whatever they're in. Sorry, not bassinet. Incubator. It's been a long day.
I like bassinet. It sounds
I'm making it sound much more rosy than it is. Yeah. But I think we still just don't really know what to do with these probiotics. Obviously, there's a lot of things going into this beyond just whether or not that child got a microbiome agent. It's the hospital environment and asking those questions of ultimately how it impacts their clinical course. But nothing here to say, go ahead and throw on those probiotics quite yet.
Yeah, it's really interesting. I think a lot of times I almost feel like the probiotic is almost like a religious thing. There's believers, and then there's, dare I say, the rest of us waiting for a little more evidence, dare I say. Yeah. And I would like more evidence. The article, Rapid Implementation of Blood Culture Stewardship, Institutional Response to an Acute National Blood Culture Bottle Shortage, was published in CID. So we've talked about this national shortage of blood culture bottles. And here we read this brief report from Vanderbilt that aerobic blood culture bottles received from their distributor July 1 through 15, 2024. So the first half of the month of July was less than 1% of the typical usage amount. Ouch. So they jump in through education and ordering restrictions to try to minimize risk. And they are able to reduce orders by 49% over a 1 week period. So they drop the orders almost in half. Now, keep up with the lack of supply, I think they need to accomplish 99%. But we read that to address this drastic shortage, we, the folks at Vanderbilt, rapidly formed a multidisciplinary team with expertise in clinical microbiologists, adult and pediatric infectious diseases, emergency medicine, nursing, communications, health informatics, and supply chain to assess utilization patterns and develop methods to curtail use while mitigating risk to patients. I guess a couple things I'll say here is, one is this is sort of hey, by the way, what are we doing here in the U.S. Having such an issue with supply chain that something like this can happen, right? Are we really doing so many unnecessary blood cultures that we really can drop our usage by 50% without any kind of an impact? Yeah, I think that there's a lot here. Any thoughts? How are you guys handling this, Sara?
So our adult side, it only impacted the fungal AFB blood culture bottles, but on pediatric side, it's all of the blood culture bottle types are impacted. I actually put a link to the IDSA CDC clinician call that talked about it, because a couple people, I think Vanderbilt was one of them, but there was multiple institutions that just shared how they're approaching the shortage. And also there's some really interesting, literature out there about blood culture stewardship, and, a lot of these things that we could implement that we probably should have already done regardless of if there had been a shortage. But it is scary that how drastic this shortage has been.
Yeah, I think, for me, I saw it, as a great opportunity to educate people, to basically say like, hey, like before you just order those blood cultures, we need to have a conversation and talk about a number of things. Like if someone has we'll say a simple pyelonephritis and you pick up an E. coli in the blood, and do we really need to repeat a blood culture to confirm, that it's going to clear if their white count's coming down and they're afebrile? Also, the timing of repeat blood cultures when we're looking for persistent bacteremia, once they're on that effective antibiotic, can we wait 24 hours before we draw that next one instead of like triggering it right at, let's say, 13 hours? So I think there has been some opportunity here to really think about what we're doing and hopefully better utilization in the future. All right, fungal. When is the show going to come out?
I don't know if you saw. Oh, I will put it in. There was a sneak peek of the new season, so I'll put it in there.
Put a link in for us.
I'll find out what you're talking.
I'll if people find me distracted, it's because I'm multitasking.
I'll think of any excuse to bring up Pedro Pascal in my book is worth it.
All right, so be sure to watch The Last of Us the next season when it finally comes out. But we have a couple, I think, interesting articles here in the fungal section. The first is the article, Clinical Characteristics and Mortality Risks Among Critically Ill Patients with Culture-Proven Coccidioidomycosis, a multi-center study in an endemic region, published in OFID. And really, it's one of those diseases that if you're in the endemic area, there's a certain familiarity. But a lot of folks outside of that endemic area, this is sort of an exotic thing. But here we are down in Arizona, retrospective chart review of ICU patients with positive Coccidioides species culture in a large healthcare system in Arizona between October 1, 2017, and July 1st, 2022. 145 patients were identified, included. The median age was 51, 69% male, 39% non-Hispanic white, 72% had pulmonary, and the rest, the different extrapulmonary manifestations were meningitis, just pure fungemia, musculoskeletal disease, and there were some folks with pericardial and aortic involvement. Now, half of the patients, 48% of the patients, died during hospitalization, and most of the patients, 91%, did receive antifungal therapy during the hospitalization. And what were the biggest risk factors for increased all-cause mortality? Big here, age greater than 60, odds ratio 7. Cirrhosis, odds ratio 13, and then sick enough to end up on a ventilator or vasopressor support, that was an odds ratio of 15. All right. And C. auris, can't miss a chance. Factors associated with poor clinical and microbiological outcomes in C. auris bloodstream infection, a multi-center retrospective cohort study published in CID. So, both of these are what can we look at our patients as far as what factors might be predictive of a bad outcome. And here we have results from a multi-center retrospective cohort of patients with C. auris bloodstream infections, BSIs, from 2 geographic areas in U.S. healthcare settings. Data on demographic, clinical, and microbiological characteristics were collected to describe the cohort, and they construct this multivariate logistic regression model to try to understand the risk factors for 2 clinical outcomes. One is all-cause mortality, and the other, blood culture clearance. So we end up with 187 patients with C. auris bloodstream infections. About half of them are male. About half of them are over the age of 65. About half of them died by facility discharge. And we'll say 66.9% experienced blood culture clearance. They do this pit bacteremia score at infection onset, and that actually was what was associated with mortality. And as you get more points, you get a worse outcome. Also comment that hemodialysis was associated with a reduced odds of microbiological clearance, and a odds ratio 3 for mortality, so higher odds of not surviving. I don't know how many of our listeners use like the pit bacteremia score, but I kind of went through and I pasted it in our show notes. But it's sort of an interesting, if the fever's, really high or the temperature's really low. So hypothermia, 35C or less, hyperthermia, 45C or higher, you're going to get a couple points. Low grade fever, 1 point. Hypotension is going to give you a couple points. You end up on a ventilator, a couple points. Cardiac arrest, you get 4 points. That's a big one. And then there's sort of a mental alertness. So the worse you are, like to the point of comatose, that's going to give you a 4. So sort of basically, I think a lot of this is super high fevers, hypothermia, hypotension, obtunded patient who's having cardiac arrest and on event. Yeah, we sort of would expect them to be doing worse.
Yeah, I had pulled this one too, and I don't think I've ever pulled up and calculated someone's pit bacteremia score, but it's like you said, those really sick patients right off to the bat, not terribly unexpected that those are the patients who are likely to die later on.
All right. And we have a couple parasitic cases that I'm going to run through, parasitic articles, before we let Sara jump in with some miscellaneous. The first one, for me, this is a fun one if people know my history, but, and they might if they are listeners, and I'll recommend This Week in Parasitism. Prior to the pandemic, that was our most popular show, as ridiculed on NPR. I'm driving to soccer practice one day, and it was like, wait, don't tell me, which of the following shows is fake. And everyone, there's no show called This Week in Parasitism. We do believe there's a show about buttons. But anyway, there's a show and it's great. The article, The Lethal Effect of Soap on Schistosoma mansoni cercariae in Water, was recently published in PLOS and NTDs. So there's this story, right, where I'm with the family in Malawi and we're at the shores of this beautiful lake, and the lifeguard is keeping an eye out to make sure the crocodiles don't come too close, and the heat's making the water seem so inviting. But what about those little Schistosoma cercariae? Well, schistosomiasis, for our listeners, is a parasitic disease which is spread through skin contact with water containing these little schistosoma cercariae. Now, drug treatment has been the main control method, but does it prevent this infection? What about soap? Maybe if I just wash off with soap after that swim and then towel off vigorously. Well, the idea here is that the schistosoma cercariae don't penetrate the skin while we're swimming, but they're actually triggered to penetrate as the water dries. This is actually true. So you get out of the water, you're all good. But then as your skin starts to dry, there's this 5-minute period when the cercariae are going to be triggered to penetrate. So you got 5 minutes to potentially intervene. So this study investigates the quantitative effect of different soaps on the mortality of the Schistosoma mannsoni cercariae. So they're going to study 4 soaps. We got 2 powder soaps, Clesoft and Omo, and then we've got 2 bar soaps, B29 and Rungu. And they're going to study this in the Schistosomiasis endemic Tanzania village. So the cercaria were exposed to the powdered soaps and the bar soaps at all these different concentrations. And this really high concentration of 1,000 milligrams per liter was selected based upon the laboratory estimated average soap concentration during hand washing. The cercaria were observed under a microscope after 0, 5, 15, 30, 45, and 60 minutes. We really need this to happen in 5, by the way. All 4 soaps can kill the cercariae, and this lethal effect was related to soap concentration and exposure time. So at that highest concentration, all the cercaria were dead at 5 minutes post-exposure with the 2 powder soaps and the Rungu, while 100% cercarial deaths were achieved between 5 to 15 minutes with the B29. So those powder soaps were more lethal than those bar soaps. And the authors conclude that considering the widely varying concentrations of soap during real-world hygiene activities and the necessity for very high soap concentration to eliminate all cercaria in a short 5-minute exposure, providing the efficacy of soap in preventing schistosomiasis is rather challenging. So I'm just not sure you're going to get your entire body sort of soaped up to that high soap concentration in time. So I'm also not sure my toweling off vigorously is where to go, as that's been my approach. But anyway. All right. The article, Treatment of Uncomplicated Hepatic Cystic Echinococosis Hydatid Disease, was published in the Cochrane Database of Systemic Reviews. Now, cystic echinococcus is a parasitic infection mainly impacting people living in low and middle income countries. Actually, a bit of this down in the Southwest, I should mention. Infection may lead to cyst development with organs, pain, nonspecific symptoms, complication including abscesses, cyst rupture, and treatment can be difficult and varies by country. Now, treatments include oral medication, percutaneous techniques, and surgery. Those familiar with this disease may recall the NICE tables based on stages that guide which therapy to choose. I have a nice one. I should have left the link in with a cartoon, but we just give, do we just give medications? Do we perform puncture, aspiration, injection, and reaspiration, the famous pair? Maybe a large core needle to break open those loculations between the daughter cysts, or some sort of surgery, open versus laparoscopic. So we have all this great stuff, but is it true? And here they include 3 RCTs with 180 adults and children with hepatic cystic echinococosis. 2 studies enrolled people aged 5 to 72. 1 study enrolled children aged 6 to 14. 1 study compared standard catheterization plus albendazole versus pair plus albendazole. 2 studies compared laparoscopic surgery plus albendazole with open surgery plus albendazole. The 3 RCTs were published between 2020 and 2022, conducted in India, Pakistan, and Turkey. Unfortunately, we learned that all this guidance is based on low certainty evidence, so firm conclusions cannot be drawn. Ideally, this disease could benefit from better studies looking at how to best manage those infected.
Classic.
It's sort of a right? Like we get all excited, and then it's like, is any of that true? Yeah, I don't know. All right. But it sounds true. So let's not let the truth stand in the way of a good story, or a lack of truth. Anyway. All right. Now, this is kind of a fun one. And I was sort of, got through it and I was like, all right, interesting. Well, the article, Blood Exposure to Babesia microti through Sharp's Injury, was published in Infection Control and Hospital Epidemiology. So here's the story. So we have a 65-year-old man with a complex cardiac history, including coronary artery disease with prior myocardial infarction and stenting, multivessel coronary artery bypass grafting, type 1 diabetes mellitus, peripheral artery disease, who presents June 2023 with fevers, fatigue, and yes, they diagnosed Babesia with 2.7% parasitemia. They get a positive PCR. They start him on atovaquone azithromycin. But 3 days later, he's found to be in complete heart block. Sort of wondering if there wasn't a co-infection here, but we'll just skip right past that. They decide to go ahead with central venous catheter for transvenous pacing. And the doc pokes himself, gets a Sharps injury from a scalpel contaminated with blood while cutting excess suture material from the patient's skin that was contaminated with blood. The exposed physician remained symptom-free and had negative thin smears, PCRs, and antibodies. And the interesting thing they bring up is, what is the risk of transmitting Babesia through a needle stick or a Sharps injury? And we don't know.
Yeah.
Yeah. So as we see more of this, that's kind of one of the things that we need to know about.
Yeah. Well, I will take us into our miscellaneous section. I thought this next paper was really cool. It's from CID, Absence of Cerebrospinal Fluid Pleocytosis in Encephalitis. So this is a retrospective study. It looked at the initial CSF profiles in about 600 adult patients with all-cause encephalitis, and they found that a quarter of patients and 23.7, or about a quarter, of those with HSV-1 encephalitis had absence of pleocytosis on their initial LP. So this group without pleocytosis still had similar proportions of infectious versus non-infectious encephalitis causes, so they were really equally likely to have had an infection. There was no pleocytosis in 19% of the infectious encephalitis cases identified, no pleocytosis in 39% of the autoimmune cases, and 26% of cases without identified cause. The absence of pleocytosis was associated with less acyclovir administration, so 48% in those without pleocytosis versus 71% with. And the sort of last conclusion is that the presence of pleocytosis was correlated with neurodysfunction on presentation, although not with worse hospitalization outcomes or mortality down the road. So there's a really nice editorial commentary that is, you can pair with this, a clear and present danger, encephalitis due to infection with normocellular CSF, from Karen Block and Carol Glazer, who were also on the Febrile Star episode that we did on encephalitis, so I have to plug that. But this is such a great study to remind us that CSF pleocytosis is an imperfect marker of brain infection. And I think we knew that HSV encephalitis certainly can have normocellular CSF early on in extremes of age, and how you really have to have that high suspicion to repeat the testing. But this is, that 24% or so that did not have pleocytosis, that is higher than what's been previously reported. And it really impacts how we use other diagnostics. Like, I'm sure plenty of people have restricted multiplex PCR assays to, some white blood cell count cutoff, whether that's like 5 or 10 or whatever they use. But I think it's a great pairing to read these together. I think it's a great paper to share with your team. Just a challenging thing to deal with, and really having to think about what the patient in front of you looks like and what your concerns are, and to keep those on your differential, even if your CSF is not, doesn't have a particularly high white count right away.
All right, and I'm going to finish us off with the article, Bearing the Burden, Podoconiosis and Mental Health, a 3-way comparative cross-sectional study in Rwanda, published in PLOS NTDs. You're going to survive over there with your tuberculosis, Sara. All right.
Sorry, I didn't know what happened.
No, I'm looking out for you. Feel free to cough, drink water, do whatever you do. So podoconiosis, right? I think, Sara, I may have been like the one who first mentioned this on one of our episodes, but it's this non-infectious neglected tropical disease caused by chronic barefoot contact with irritant volcanic soils, right? So it looks actually a lot like lymphatic filariasis. And the first cases I saw of this, I was actually in Western Uganda, right there at the Rwandan border. You're looking up at these beautiful mountains, close enough to Rwanda, right, that it was like 3 miles away that some rebel force came across the border, later. It's actually the next morning that I had seen these folks. And you see these folks, and initially you think, oh my gosh, this looks like just everyone here has lymphatic filariasis, but it's a little bit different, right? And it actually has this nickname of mossy foot. So if you look closely, it's a little bit like almost like a moss on the toes. It tends to be both feet, tends to be bilateral. Really a horrible disease. So here they're actually looking really at mental health impacts. They're using this depression, anxiety, and stress scale, as well as the WHO quality of life scale. And the investigators assessed each group's mental health, quality of life status, and the results were really telling. I mean, the people affected by the Podoconiosis displayed considerably higher odds of severe depression, anxiety, stress symptoms, and the family members also had a lot of this higher anxiety. And so this stark mental health burden highlights the necessity for comprehensive podoconiosis morbidity management programs, incorporation of mental health support for patients and their family. And this is preventable. And the most effective intervention is just to wear shoes. So I know when we were there with my buddy Kai Scheifer, we all kind of gathered funds, and they make shoes out of old tires, right? So they cut like a sort of
I feel like you've told me this.
And then they use rope to sort of, and that's really, very preventable, but really a horrible neglected disease here. All right. And Sara, does that bring us to the end?
That brings us to the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love your questions, comments, and paper suggestions, so shamelessly send your papers our way for discussion at puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV. microbe.tv/contribute, or go to Parasites Without Borders and click on the donate button.
I'm Sara Dong. You can find me at swindong at Febrile Podcasts or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.